So our next speaker, our last speaker, is going to be speaking on a case, and this is Ayaaz Sachedina. We actually have Dr. Jessup as well as our keynote, but our last speaker for the session here is a case presentation by Dr. Sachedina, my worst TAVR complication. Thank you.
So hello everybody, I'm Ayaaz Sachedina. I'm visiting from Canada. And so I had the pleasure of doing my interventional heart failure fellowship at Memorial Hermann here before going back to Canada, and I now work in Calgary, Alberta. And so last year was asked to present my most terrible TAVI complication, and had a case just a couple weeks before the symposium, and I had to use basically every tool that I'd learned during my interventional heart failure fellowship, MCS, etc. It went great. And so when Dr. Jumian called me in September, 4 months after that, and say, I'd like you to present another terrible TAVI complication, I was like, what do you think I'm doing, like, up in Canada? And I said, I don't really have one. Things are actually going pretty well. And you would think that my old program director would say, hey man, that's great, good job. But his response was, well, it's September now, let's give it a couple months. And I'll check in with you again, and then we can decide. But so I actually don't have a TAVI complication, thankfully. But I did have a case that sparked a lot of debate at our center that we thought was a good fit, so we're going to talk about that. So to give a little context, Calgary versus Houston, having worked in both. So in terms of the population we service, Houston is 2.2 million people. Calgary, our catchment area, is about 2.1 million people. Yesterday I counted the number of cath labs in Houston. There's 22. In Calgary, there's 1. And so you can imagine we're pretty busy and do a lot. But the patient I wanted to talk about that sparked so much debate at our center is actually a 43-year-old. So this is a 43-year-old guy, came in with an NSTEMI and found to have multivessel coronary disease. Things got a bit more complex from there. He actually was on dialysis for end-stage renal disease. He has tertiary hyperparathyroidism, all the cardiac risk factors, and his end-stage renal disease was from uncontrolled diabetes in his life that had actually gotten a lot better. And so he had 3 echoes at the time around his initial presentation in February of 2022 that showed borderline preserved heart function with an EF of 51%, and all the echoes suggested mild aortic stenosis with a mean gradient of 14, and that was on both echo and cath lab across the valve pullback, which were exactly the same actually. So he underwent a CABG with a 2-vessel CABG. Our center does a lot of arterial grafting, but in his case, the surgeon was noted really challenging anatomy and was also concerned about using the LIDA in the presence of a left AV fistula. And so he got 2 saphenous vein grafts and had to go back to the OR a couple times actually because of bleeding and friable tissue issues. They had an issue the first time with cross clamping, bunch of stuff, but he eventually got discharged home and was feeling well. So 9 months later, in November, he actually presents to hospital in cardiogenic shock, gets intubated, elevated lactate on inotrope suppressors, all of that fun stuff. And this is his echo now. 9 months after, you can see that his heart is not moving very well. You can see that his RV is actually now dilated and also dysfunctional. And his aortic valve looks like a calcified mess. And so his echo shows that he has reduced heart function now, a new cardiomyopathy, EF less than 35%, and it now is suggestive of low flow, low gradient aortic stenosis. He gets a cath showing that the bypass grafts are patent, coronary vessels look fine, but his mean gradient now across the valve, despite that EF, is over 40. So something's changed a lot just in 9 months. And so we had a discussion at our multidisciplinary heart team rounds. I have excellent surgical colleagues who really invest and advocate for the patients and have great technical skills, but every surgeon, after reviewing how the case had gone in February and the patient's anatomy, deemed that the patient was not a surgical candidate at this point for aortic valve intervention. And there's 4 of us on the TAVI team, 3 of us were in the room, and the other 2 of my colleagues on the TAVI team who are more experienced and more senior, I also did not think that the patient was a TAVI candidate. And they brought up several good points, but for the most part, the entire multidisciplinary heart team suggested palliation for this 43-year-old guy. So they brought up some good points as to why not to proceed. Well, they said he has shock and biventricular dysfunction, and it's not just the left side that's involved, it's the right as well. His prognosis is poor, very high procedural risk, he's too sick, all of that fair. He also has this tertiary hyperparathyroidism. What the heck has happened to the valve just in the past 9 months when we put a prosthesis in? What's going to happen to that one? His calcium score is above 5,000. In fact, his CT TAVI protocol that we'd done just before the discussion showed that he actually had fractures in multiple places and modeled bones, and they were worried about rehab potential. He has end-stage renal disease. We know that these patients on dialysis do have worse outcomes with TAVR as well. And then at our center in 2022, TAVR was still a limited resource. Despite the fact that we service 2.1 million people, I had, as a universal healthcare system, had 150 funded cases per year. That meant that we went above it every year, but the 151st case and thereafter, I had to submit special paperwork just to get approval for the valve. And we were doing TAVRs 1 day a week. So those are the reasons not to try, but in our minds, there's also several reasons to try. Number one, this guy was highly functioning. He underwent CABG 9 months prior and walked into the hospital in cardiogenic shock. He had ventricular dysfunction that we couldn't identify another cause from and we thought was potentially reversible with valve intervention and was related to his AS. We had both ENT nephrology willing to consider his tertiary hyperparathyroidism surgery, consider him for renal transplant if we could resolve his heart issues. And finally, he's 43. I just did TAVI 2 weeks ago on a 97-year-old who climbed up 4 flights of stairs with me in the hospital. If I'm willing to do a TAVI on a 97-year-old, I'm damn sure I'm going to do it on a 43-year-old. So I actually went to the patient and I said, listen, this is not good. And I don't know if this is the right thing to tell him, but I said that everyone's telling me that if we don't do something, there's a 100% chance you're going to die. And if we do try something, there's a very slim chance that it might make a difference. I don't know. And his response was, I'm in. Let's do this. And so our ICU team had done an amazing job. He had been extubated. He was on room air. He was still requiring a little bit of support, but his lactate had normalized. And remember, we do TAVI 1 day a week. So after the multidisciplinary heart team discussion, that was a Friday. Our next TAVI day was the following Thursday, which is what we do. And the goal was to try and get him to that. But as we know, AS patients, when they start to fail, they fail fast. So 4 days before TAVI, I get a call on a Sunday from my advanced heart failure colleague and said, hey, he's not doing well. We're having to go up on his inotropes, his lactate's climbing. And so we did a quick shock team consult. He unfortunately was not an advanced MCS or ECMO candidate. They didn't feel he had an exit strategy if we did go on to something. And so the question was, well, can we still do this? So on a Sunday night, spend 4 hours on the phone, finding a team. So one of my colleagues in the cath lab was willing to give me some time in his lab the following morning because I wasn't actually scheduled. One of my colleagues from cardiac surgery was actually willing to come in from vacation to back me up on the TAVI team. I had a cardiac anesthesiologist willing to stay post-call on the Monday morning to help as well. And then our allied health team was willing to switch their schedules to give me our TAVI allied health team in the cath lab to come into the room. And so when he rolls, first thing in the early hours, a few hours later, he's on 3 drips of inotropes and pressors. His lactate's 7, still going up, and his systolic blood pressure at that point is 67. I really have to hand it to my colleague from anesthesia who did an amazing job of resuscitating him and getting him intubated in the room, and we go ahead. You can see that's how fast his heart rate is with us doing a room. We're not pacing there. That's how fast his heart rate. He was sick. And so we deployed a sapien valve, undersized to 29 a little bit. And I want to say that his heart rate slowed down because of the valve immediately made an impact, but I put him into third-degree heart block for a few seconds, so that's why his heart rate's so slow. But we got a very good valve result. And what happened afterwards? Well, amazingly, within 24 hours, he's off everything. This is his echo. Not too long afterwards, things are starting to wake up. And over the subsequent weeks, his heart function goes 35, 45, 60. His RV actually wakes up as well. The size actually decreases. It was pretty amazing. And he got, not because, don't want to say this one was from me. It was a month later, but he went back into third-degree AV block and needed a pacemaker. And so 4 months after that, undergo surgery for tertiary hyperparathyroidism. And a year after that, undergoes a renal transplant. And so now he's at home, feeling really good and living with his family and enjoying his life. And so when I reflect on this case, because this one is still, discussed at our center a little bit, and so we know that TAVR can be an option for patients with cardiogenic shock. This is the youngest patient I've ever done a TAVR on, and I understand that there are challenges with that too, because now when we're looking to the future, what's going to happen to him next when this prosthesis fails? But we've given him a chance. And so we know there are people at this conference who are on this paper, including Dr. Carr, who's sitting up here, who have shown that TAVR is an effective option for patients with cardiogenic shock, particularly when they don't have many other options. We also know that patients on dialysis still need some additional considerations to patients who are being considered for aortic valve intervention. This is a recent study showing that in over 3,500 patients, the outcomes for patients who are on dialysis and undergo TAVR still aren't as good as the patients who are not. And in our center, it used to be no dialysis patients whatsoever. Now we're now doing patients on dialysis who particularly have an option for transplant thereafter and getting good results with that also. And then finally, on our end, we have to do further work to reduce our resource constraints. So we've actually had, our outcomes have allowed our province or state to fund us now to 300 valves per year, which is really good. We're increasing our TAVR capacity to 2 days a week, starting in actually 2 weeks from now. But the biggest reflection that I have from this is that morbidity and mortality rounds are important, but I actually think survival and success rounds may be also. Because all the people in this room who are here listening to the case, in my mind, are already the ones who believe, who show up to these conferences because they think that these things can work. But on a local level, you know, if this case had not gone well, I can imagine that it would have been the first one discussed at M&M rounds. But we don't really have a forum often, even at a local level, to discuss the rounds, discuss the patients that did go well that we weren't expecting to. And so I'm actually starting our own survival and success rounds with a couple of my colleagues at our local center to highlight the cases that, you know, we took the chance and they worked out. And so in the end, thank you so much for having me again. I'm going to put a quick plug. So. We had 2,000 people at the Shock Symposium here this year. Just a quick plug for our small Canadian conference called Cath Shock, which I like to think is the little brother to the Shock Symposium. And thank you, Dr. Jumian, for helping me start that. So if
It's a
anybody's
big province,
interested,
though.
Sorry?
It's a big province.
It's a big province. So if anybody's interested in coming to Calgary, please come join us for Cath Shock this year. But thanks.
Thank
yeah.
you.